Hi, I'm Dr. Walid elhabeb, consultant heart failure cardiologist and assistant professor of medicine at King Saud University and the president of the Saudi Heart Failure Working Group. Today I'm going to talk through an educational series of lectures about management of diabetes, and specifically today about the relationship and management of diabetes and heart failure. So why diabetes and heart failure? Heart failure, people with diabetes have a 2 to 5-fold higher risk of developing heart failure. And those with diabetes have a 60 to 80% greater probability of cardiovascular death and all-cause mortality in those with established heart failure. In several studies, including local data, the incidence of diabetes and heart failure is tremendous. About 60% of our cardiovascular and heart failure patients have diabetes, so the correlation is very strong. But in other studies showing the outcome of patients with diabetes in different types of heart failure, as you can see in this slide, those with heart failure with reduced ejection fraction and those with preserved ejection fraction, you can see the significant impact of diabetes on the mortality of patients when they have diabetes, whether they had heart failure with reduced or preserved ejection fraction. And unfortunately, all the studies that showed intensive glycemic control did not have any impact or did not show significant impact on the risk of heart failure, as you can see in the familiar and famous studies that have been studying diabetes, like ACCORD, ADVANCE, UKPDS, and VAT. And overall, as you can see here in this slide, did not show any impact on the heart failure and risk of heart failure outcomes. Previous cardiovascular outcome trials have not shown a benefit of heart failure outcomes either, as you can see here in different drug trials, whether it was the SAVOR, TIMI, the saxagliptin, the EXAMINE, alogliptin, sitagliptin, and lixisenatide. All these studies did not show cardiovascular outcomes, even with the control of diabetes in these studies. Let's talk about the heart failure population in the diabetics. And I'm going to touch on that through the EMPA-REG trial, which you're all familiar with. And this trial randomized more than 7,000 patients into 3 arms. The empagliflozin arms 10 milligram and 25 milligrams versus the placebo group, which received all indicated other medications. The key inclusion criteria for this study were adults above 18 years of age with type 2 diabetes, a BMI of less than 45 kilogram per square meter, a hemoglobin A1C between 7 and 10%, an established cardiovascular disease. So those who had a prior myocardial infarction, coronary artery disease, stroke, unstable angina, or occlusive peripheral arterial disease. The main exclusion was those who had significant renal impairment, a GFR of less than 30 mils per minute. What did it look at? It was mainly looking at the cardiovascular outcomes, and it had primary and secondary outcomes. The primary outcome was the 3-point MACE, time to first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke. And the key secondary outcomes was the 4-point MACE, time to first occurrence of CV death, non-fatal MI, non-fatal stroke, or hospitalization for unstable angina. But it also had other pre-specified secondary outcomes, mainly cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for heart failure, and all-cause mortality. All cardiovascular and neurological events were adjudicated by independent mass clinical event committees, and that was very important for stopping any study. What were the main outcomes out of the EMPA-REG? The empagliflozin, in addition to standard of care, reduced cardiovascular risk and improved overall survival in adults with type 2 diabetes at high risk of cardiovascular disease. It showed a 14% reduction in 3-point MACE, a 38% reduction in cardiovascular death, 32% reduction in all-cause mortality, and 35% reduction in heart failure hospitalization. The overall safety profile of empagliflozin was consistent with previous clinical and current label information. There were subgroup analyses, and today, because of our main focus and topic about heart failure, this is what I'm going to focus on, the subgroup heart failure analyses. Patients were stratified by baseline characteristics, including the presence of investigator-reported heart failure. The specific heart failure outcomes studied were two types, the pre-specified and the post-hoc. The pre-specified were heart failure hospitalization or cardiovascular death, excluding fatal stroke, heart failure hospitalization or death from heart failure hospitalization alone, and investigator-reported heart failure or serious heart failure. The post-hoc analysis included introduction of loop diuretics, so basically worsening heart failure, so you will only introduce it if you have the patient requiring more diuresis. Cardiovascular death, all-cause mortality, heart failure and adverse events according to the presence of heart failure at baseline. And all-cause hospitalization in general, not heart failure specifically. The baseline characteristics were insignificantly different between both groups, whether it was the gender, race, the hemoglobin A1C, the BMI, systolic blood pressure, all baseline characteristics actually were the same, including the cardiovascular risk factors that were included in the study. The medications used, other medications used, oral hypoglycemics or insulin, were also similar between both groups, whether the patients had heart failure at baseline or did not have heart failure, as well as antihypertensives and anticoagulants. What did that show? What was the data? As you can see here, a significant reduction in heart failure hospitalization and cardiovascular death of 34% in those on empagliflozin compared to placebo. Heart failure, hospitalization, or cardiovascular death was not different by baseline characteristics, whether the patient's age was less than 65 or above 65, or if the GFR was totally normal or impaired, reminding you that those less than 30 were excluded, but whether the patient had a GFR above 90, 60 to 90, or less than 60, between 30 to 60, there was no difference in the use of significance of heart failure hospitalization reduction with empagliflozin. Even with medication use, not any medication imposed any significance on the results. Those who were or were not on insulin, those who were or were not on ACE and ARBs, beta blockers, diuretics of all kind, and mineralocorticoid receptor antagonists, it was universal across all groups. Heart failure hospitalization or death from heart failure was reduced by 39% in those on empagliflozin too. And investigator-reported heart failure hospitalization or serious heart failure was significantly reduced by the use of empagliflozin. Time to first introduction of loop diuretics, as we said, as a sign of worsening heart failure, has been significantly reduced by the use of empagliflozin compared to placebo. And what is remarkable here, and you can see in all these graphs, how it splits very early in the course of the disease. And even with a longer-term follow-up, more than 5 years, it's still showing the significant improvement. Outcomes were also consistent in patients with and without heart failure at baseline, and that was the main question main question raised by people. Did it differ if the patient had a heart failure to start with or did not? And as you can see here, heart failure hospitalization or cardiovascular death, heart failure hospitalization alone, cardiovascular death alone, and all-cause mortality, whether the patient had or did not have heart failure at baseline, still maintained the significant reduction in heart failure outcomes with the use of empagliflozin. Adverse events were not different, as we know in the overall study, but also in those who had heart failure or did not have heart failure at baseline. The more than one adverse event was not significantly different. Severe adverse events or serious adverse events were all not significantly different between both of them. Deaths were not significant, and any adverse event that led to discontinuation was similar between both groups. Hypoglycemia as well, requiring assistance, was not significantly different between both groups. So in summarizing this data, as you can see here, patients on empagliflozin showed a significant reduction across all outcomes, whether it was heart failure, hospitalization, or CV death, heart failure, hospitalization, or death from heart failure hospitalization alone. All-cause hospitalization was significantly reduced, and worsening heart failure or serious heart failure was significantly reduced. In other ways, as you can see in this slide, heart failure, hospitalization, or cardiovascular death was reduced by 34%, heart failure, hospitalization, or death from heart failure by 39%, heart failure hospitalization by 35%, and all-cause hospitalization by 11%. Investigator-reported heart failure by 30%, and investigator-reported serious heart failure by 31%. So the effect of empagliflozin were consistent in patients regardless of the presence of heart failure at baseline or not. Interestingly, later on, another sub-analysis of the EMPA-REG for patients with heart failure on risk for cardiovascular death and heart failure hospitalization across the spectrum of heart failure risk in the EMPA-REG outcome trial was reported. And that simply meant that, and I'll show you that in a while, that empagliflozin reduced the risk of cardiovascular death and heart failure hospitalization in patients with type 2 diabetes and established cardiovascular disease in the EMPA-REG trial. And this trial investigated, or this study, sub-analysis, investigated whether the benefit of empagliflozin was observed across the spectrum of heart failure risk. So again, just to remind you, there were 11,000 patients screened, or more than 11,000, 7,000 randomized, and more than 97% completed the trial. So that's a very good number. More than 99% had vital status available. 3.1 years median follow-up, and across the three groups, the placebo, empagliflozin 10, and empagliflozin 25 on top of standard care. The hospitalization for heart failure was defined as an event requiring an admission to an inpatient unit or a 12-hour stay in emergency room as a result of clinical manifestations or a new or worsening heart failure. The risk categories were calculated according to a 5-year risk estimation of patients without prevalent heart failure at baseline. So a 5-year risk of occurrence of heart failure was considered low to average if it was less than 10% risk of developing heart failure in 5 years. It was high if it was about 10 to 20% risk of developing heart failure, and more than 20% risk was considered as very high. And 67% of the population studied in the EMPA-REG had low to average risk, 24% had high risk, and about 5% had a very high risk. So the purpose of this risk stratification was to assess the impact of empagliflozin on cardiovascular death and heart failure mortality on the totality of those versus those without either baseline or incident heart failure. Did it maintain its benefit across the three categories of risk group? And again, the baseline characteristics between the three groups, whether they had low, high, or very high risk, or those who already had heart failure, was not significantly different. So in patients without prevalent heart failure, the heart failure hospitalization or cardiovascular death in low average risk patients was significantly reduced by 29%, as you can see. And in high-risk patients, it was more significantly reduced, as you can see, by 48% reduction. And in very high risk, about 45% reduction. So it maintained its significant impact and power on all categories of risk, from low to high to very high. And as you can see, whether it was heart failure hospitalization or cardiovascular death combined, heart failure hospitalization alone or cardiovascular death alone, they were all reduced significantly across all the three groups. Okay, now in patients with prevalent heart failure, already having heart failure at baseline, as you can see, there was a significant reduction in cardiovascular death across all subgroups of these patients, whether the patient had heart failure hospitalization or not, whether the patient had heart failure at baseline, and those who developed adverse events. So even if you had a hospitalization or had an adverse event, those who were on empagliflozin had a much less cardiovascular outcome, better cardiovascular outcome, less death when they were on empagliflozin. And those with a heart failure burden or without a heart failure burden, the ones that we just mentioned, had a significant reduction in cardiovascular death. And as you can see, the time trajectory of benefit for heart failure hospitalization starts very early and maintains its benefits over the years with follow-up. And reductions in the heart failure risk for heart failure hospitalization with empagliflozin were observed by the first month and persisted for the duration of the trial. So in conclusion, the current analysis analyses show that the SGLT2 inhibitor empagliflozin reduces adverse heart failure outcomes across the spectrum of heart failure risk. Rapid and robust benefits were observed in those with baseline incident heart failure versus those with no heart failure burden, as well as in those at low and high risk for heart failure. Thank you very much.